that film?
There was a Russell Crowe one, wasn't
Yeah,
it?
yeah. I mean,
I didn't see it.
if you do get a chance to watch the film, it might be worth watching A Beautiful Mind. And the film's portrayed on Nash Jr. I read the book actually, ironically enough, and he had schizophrenia. Well, it was documented that he had that in the book, and the movie was made. So the movie, I believe, went on to be an Academy Award film, and it's quite an interesting account of his life. If you don't get time to read the book, it might be worth watching the film. And Russell Crowe plays the role really well, I think, and he had a lot of the symptoms of schizophrenia, and he'd gone on to win the Nobel laureate in economics. So obviously he went on to do well, but he'd sort of suffered in his journey, with delusions and all the other symptoms around schizophrenia. But it's a really good film to watch, and I think one thing that does certainly highlight is the sort of spectrum of the condition as such, in the sense that you might have a university professor who has a diagnosis with schizophrenia, but on the other hand, you could have someone who is struggling to function day to day. And we think of psychosis, the continuum of psychotic experiences where we mentioned earlier, things can fluctuate. You can be fine one day, the next day, for one reason or the other, an adverse event, or a number of things really. So the sort of continuum. But it's a really interesting film to watch anyway. But equally in saying that, there's been a number of people who, famous people who've had schizophrenia as well. I think Pink Floyd, Syd Barrett, I believe he had schizophrenia as well, amongst other people too. Well, what is schizophrenia? It affects 1% of the population in the UK. It's a severe psychiatric disorder characterised by major disturbances in thought, emotion, and behaviour. The onset of schizophrenia is typically in late adolescence or early in adulthood. So we sort of talked about that before the break. There's no diagnostic pathology for schizophrenia, and diagnosis is currently based on a cluster of symptoms, and these are described as positive, negative, and cognitive. So you've got a mental health professional, be it a psychiatrist, who will use the ICD or the DSM and have a variety of different questionnaires and protocols to achieve a diagnosis, which makes the diagnosis in one sense controversial, in the sense that you ever read the work of Thomas Saz and I think Voss recently, the researcher, talked about how the diagnosis will change, because obviously there's various pathways to the condition and symptoms. But that's another story for another day, and I'm more than happy to send you some sort of emails on that too, because it's not part of this course, but I'll send you that. And I don't profess to be a clinical expert in this area. I'm only going off what we're covering on this course, and obviously what I've done as a learner on other courses myself, on modules I've covered, and dissertations I've written, so on and so forth, whenever I've sort of covered this on the courses that I've been on. And so on and so forth. So there's basic clinical features we're going to sort of talk about. Going forward, how does it impact people? Well, the symptoms of schizophrenia can be broadly categorized in positive and negative. Positive, negative. Positives include delusions, hallucination, disordered thinking, and disorganized speech. Okay? And we'll sort of show you after the break a couple of videos to demonstrate that as well, and the other conditions we cover as well. It's not positive in the sense that positive being good. It's in addition to. So delusions, hallucinations, and in the film I mentioned before, Nash, he sees these illusions. There's this, if I recall now, because I actually read the book before the film, so I've got a bit of distorted view on the film. I believe, if I recall, there's this girl he sees, a young girl he sees, very frequently, and he's sort of having this dialogue with her. But she's not there, but equally saying that he believes, from a delusional point of view, he believes that he is in a situation where there's a conspiracy against him, okay, run by the government, something along them lines. So this huge conspiracy around him, and he's sort of got this information, sort of cutting a long story short. So these sort of those categories. So some of the myths are, well, myth number one, that schizophrenia, they've got split personality. That's a myth. Okay, we'll touch on that. People with schizophrenia. People with schizophrenia have, the research suggests, a lower life expectancy. And that might be down to a number of factors, as well as the medication, no doubt. That's obviously, medication is really important, but equally it's got adverse effects too. So it's, I think, 20 years less, if memory serves me correct, as a general rule. The myth that people with schizophrenia can't recover. They can recover, and some do. Okay, people with schizophrenia need to be monitored at all times. That's another myth too. And people with schizophrenia are dangerous. It's another myth as well. They're more likely to be more harm to themselves. Okay, and that's what the research suggests. But I'm sure we've all seen horror stories around schizophrenia on the tabloid press, and so on and so forth, which actually doesn't sort of give you a full portrayal. So I mentioned before that up to 20 years less life expectancy according to the research, and that might be the physical effects of a number of factors too. Okay, 20% have significant improvement, and 30% have recovery. That's what the research suggests. So the reality is, from a neurotransmission point of view, it's an example of how deficits in neurotransmission can cause mental health disorders. Now, I'm going to sort of cover what's protocol on this course, but do email me, and I'm happy to email you some of the stuff I've come across on my journey on dissertations that I've wrote in this area. So do email me if you want that. See, but there's overlap other conditions too. Okay, so what does overlap with, do you think? Well, bipolar and major depression. So schizophrenia patients display cognitive impairments. In contrast, in schizophrenia, the characteristic is psychotic episodes consist of both positive and negative symptoms too. And we'll sort of touch on those very shortly. So it's three categories: positive, negative, cognitive. Three categories. Okay. So the positive symptoms are described as additional features that are not ordinarily present. So it's not positive as in grey, positive. It's additional features, as I mentioned before, they're not ordinarily present. Example: delusion, hallucination, and that may be auditory or visual, or a thought disorder. So I mentioned the film Beautiful Mind. He sees this girl, a young girl he speaks to, amongst other people too, but also he sees this guy that's meant to work for the government as well. But you're not sure in the film if it's real or not, because it's so vivid. In this film, it's so vivid. He actually sees the guy and he talks to him. It's part of his conspiracy theory. Okay? Delusions occur, and 90% of the patients represent an idiosyncratic belief or impression, which is maintained despite being contradicted by reality or rational argument. For example, I'm being watched by people from another galaxy. Okay? So the point being there is that, irrespective of how rational the argument is, to counter that, then obviously it's idiosyncratic belief where the person can maintain that belief. So the point, I can't remember who said the story. I can't remember who it was now, but someone had mentioned that. Someone had mentioned about, this person believed he was dead, okay, didn't believe he was alive. And basically what had happened was the counter-argument was that if you're dead, you don't bleed. Okay, you shouldn't bleed. And that was a counter-argument. and the point being is the guy then proceeded to sort of rationalise and to demonstrate he would bleed to sort of signify that he wasn't there. That was meant to be, not that one recommends that someone does that situation, but then even after the person could demonstrate that he would bleed, he still went back to the belief that actually, you know what, I can't believe it, dead people can bleed in adverse to, and that was a story I had on a course. I don't remember who the lecturer was, but that's to give you an idea how idiosyncratic is. It's a belief that they hold within themselves. So rather than say, well, I'm bleeding, I mustn't be dead, well, can you believe it? Dead people can actually bleed. Which is, yeah. So hallucination generally auditory. The research suggests 70% in patients, they hear the voice. And some interesting research, by the way, being done around avatar therapy. And I've been reading on that. And you can email me on that. I've sort of come across the literature, and it's really, really interesting where the avatar therapy, they create the avatar and talk to the avatar. That's another story for another day. But that occurs in 70% of patients, and they often come from outside. And it's often, critical chain of thoughts. But they can also be visual and relate to smell, taste, or touch. Thought disorder may be remonstrated with disordered speech, including rapid change of subject. Okay, so the actual speech itself may not seem to make any sense in respect to the structure of it, and it could be just a change of subject. So invented words or inappropriate response emotionally to other people in a specific situation. Some of the sort of key features around thought disorder. Okay, negative symptoms. And they are a loss of reduction of normal function. So examples, reduced speech, lack of emotional facial expression, motivation, once enjoyed doing something but don't enjoy doing it no more. Okay, a diminished ability to begin and sustain activity. So the motivation to do the activity might be there, but just carry it through might not be there. You might pick up and do something and think, well, actually, you know what, but then sort of not do it. Anhedonia. So you enjoy doing something like watching the football, going for a walk, but you don't enjoy doing it no more. You withdraw. Okay, social withdrawal. And that's in depression too, the overlap. Anhedonia. The cognitive symptoms refer to impairments in cognitive domains, and they can affect people's ability to sort of hold a job and just general day-to-day life. So they can do working memory, spatial memory, attention, executive functions as well. So the executive function being the frontal part of the brain, the orchestra of the brain, planning, decision making. So a combination of these symptoms make it difficult to interact with people, and obviously different people are affected in different ways depending on the severity of each domain. So let's sort of think about, from the schizophrenia can take several life courses over a lifetime of the patient, and that can be one of four categories. So number one, a single episode of psychosis. Person recovers with no lasting impairments, and that corresponds to about 20%, suggests the literature, in schizophrenia, patients with schizophrenia. Group 2 show repeated episodes of psychosis, also referred to as relapse remit, with no lasting impairment, and according to the research, that's about 35% of patients. Group 3 show repeated episodes of psychosis without full recovery to pre-symptomatic levels of functioning. That's about 8% of people, suggests the research. And 4 is, you could argue, the most serious, and they show repeated episodes of psychosis which increase in severity and associated with no recovery to pre-symptom level. And that's about 35% according to the research. on average. So it can be very devastating in that respect. Okay. So, possible causes according to the research. The studies around epidemiological studies, a combination of environmental factors, but evidence suggests there's genetic risk as well. Okay, so there's a number of theories around schizophrenia, and there has been. We don't cover them on this course. I've read up on some of them on my own journey whilst doing study for various modules throughout university and so on and so forth. So I'm more than happy to sort of send you some of my, you care to read. It's up to you. There's other studies out there, but there's a number of things out there we don't sort of get time to cover on this course. But I suppose where we are, one would think at this point, is environmental factors. So there could be factors genetic as well that propose a risk as well. So it's interaction between environment and gene that generally determine the clinical outcome in terms of symptom severity, long-term outcome, and life course.
So genetic, but environmental includes substance use and that
well, it could be. So preterm birth, exposure to infection or inflammation in utero, early postnatal, exposure to social stress, particularly during adolescence. Childhood trauma is a risk factor. So, for example, trauma attachment. You can look at the Palo Alto theory around it. So, what goes on in a family, can maintain a homeostatic balance at least. It may not cause it. But the double bind theory, for example, it may not cause it. Now we've got enough research to know it may not cause it, but it may maintain homeostatic balance. So, for example, if the child, the best chance for a child to survive as a human being is to be loved by the parents and have that love. But if the parents don't demonstrate that love, the child might just believe that the parents love or want to believe. But then equally, they get conflicting messages, because the parents are behaving in one way, but on the other hand, the child wants to believe the parents' love because it knows to survive and needs that love. But if they're not being attended to, not being changed, not being hugged, not being nurtured, it thinks otherwise. So, the parent might turn around to the child and say, with his or her fist, and say, "I love you," but that does that sort of make sense? So at least that might maintain the homeostatic balance in that respect. But obviously, from a theoretical point of view, there's been a lot of theories. Cannabis, probably the most vulnerable period is during adolescence, as well as increase the risk. But equally, we know now through genes that nothing's really a straightforward line. So one person could, for example, smoke 100 packets of cigarettes a day and not get cancer. One person never smoke and get it. Not that I'm advising to smoke or risk, but they're risk factors. There is a component in the research literature in cannabis, and particularly the grade of cannabis that a lot of young people no doubt are going to smoke. That skunk, they call it skunk because it stinks, and there's obviously components in there. But if you want to read more on that, I would suggest you read the work of Professor Robert Murray from King's College, and he, being the clinical expert in that field, you can read some of the work around that area, and it's quite fascinating around that. Obviously, there are components in cannabis that are useful for other conditions and can be useful, but the point being is that there is components in cannabis that can promote a risk in that respect. But because of time, and we're covering on this course, we won't go into too much detail, but you can read that Professor Murray, Sir, I believe. But anyway, that's another story. Is it heritable? Well, it's highly heritable condition. and you know, we look at the studies on twins, identical twins, and you'll see genes aren't the only thing, because one twin might get, one twin might not. So it shows the environment factor. Genetics are complex, and they break down into rare variants that have large effects and highly penetrant. So examples of this is the DISC1 gene and deletions of the gene known as NEURIX1, although there are others as well. So most common are variants of small effects, which there's interactions of all genes. So there's often referred to as a polygenetic score, meaning the number of these small mutations that you have in your genome is the interaction of those environmental factors and genetic risk factors that can determine the clinical outcome. So it's not one gene per se as such, it's the interaction of a number of genes in that respect. But one thing around schizophrenia is the sort of research does suggest dopamine. So I think in my infinite sort of wisdom, not being a clinical expert in this field, but in the research I've done in this area for the studies I've done, there does seem to be deficits in neurotransmission to underlie the symptoms. The dopamine hypothesis says an increase in dopamine neurotransmission in the mesolimbic pathway, which leads to abnormal levels of dopamine in the nucleus accumbens and the striatum, which are thought to underlie the positive symptoms. So, in essence, there is high levels of dopamine, or higher, so to speak. Okay, but obviously that's, you know, something that we can talk about, or something that you sort of do your own research and go forward. So, about the course, so mental health first aid is one of the components we cover for a variety of different mental health disorders on the course, and we're going to touch on this again tomorrow as part of the assessment criteria for the course. But for schizophrenia, one thing to think about mental health first aid is the person may be reluctant to seek help or disclose symptoms. Okay. It's particularly important to approach the person sensitively, with degree of sensitivity, and this is according to, you know, the active IQ or EMET. If they're not comfortable talking about it, don't take it personal, but do explain that you are available to speak in future, if it's within your role and remit, or, you know, in a situation where you're available to speak and identify the behaviours of concern. Okay. If they want to talk, allow them to dictate the pace of the conversation, and escalate the person showing signs of mental health crisis. So if there's immediate risk of harm to themselves, others, seek help immediately. Okay, and there's some sort of guidelines according to the Active IQ program. So if someone's having a really severe psychotic episode, call for appropriate help immediately. Okay. Stay calm, as calm as one can be. Speak quietly, clearly, concisely. Okay. Do what they ask you if it's safe to do so. Okay. If they tell you to go away, or can you make me a drink, a tea, or so you consider there's a risk involved in what they tell you to do. Find out if they have a mental health crisis card. If so, follow the instructions on the card. Okay. Find out if there's people they have that trust you can contact. Access if it is safe for them to be alone. Okay. Keep them and yourself safe, as they may act on their hallucinations. Okay. And when professional help arrives, if they are known to the person, explain who they are and why they are there. Okay, these are according to the protocol on the active IQ level 2 mental health course, so to speak. So what we're going to do on that note, before we break for lunch, is an exercise. Okay, we're going to do an exercise shortly before we sort of break. For lunch, we'll do an exercise. We've got 10 minutes to an exercise. I'm going to do a bit of role play with someone shortly. I'm going to do an exercise between each other. So